Welcome back to the OrMobility Podcast, where we give you straight talk and smart strategies for moving better, getting stronger, and living pain-free. Hi, I'm Dr. Garrett Stroup. I'm a doctor of physical therapy and a movement coach. Today, we are going to be diving into a topic that every lifter, weekend warrior, office worker, and overhead athlete needs to hear: the interconnected chain of your thoracic spine, shoulders, and elbows. If you've ever had shoulder pain that didn't seem to get better, or elbow pain that flared up out of nowhere, or just felt like your upper body was off, this episode is for you. We're going to bust myths, explain what really causes dysfunctions, and give you a framework for a long-term resilient body. Now let's jump in. So we're going to first talk about the thoracic spine. Now, you may have seen other podcasts where I reference the thoracic spine, but I want to just re-go over these concepts. So I like to call the thoracic spine the forgotten middle child, or the forgotten middle child. And it's forgotten for a reason. There are 12 vertebrae. There are 24 ribs. Your first rib is right up here. And there's 127 joints in your thoracic spine. It's the structural base for your neck, your shoulders, and your arms. The primary movements that are involved are rotation, extension back, flexion forward, and side bending, or lateral flexion. Side bending and lateral flexion being the same thing. The primary muscles are your paraspinals, like your spinalis, longissimus, and iliocostalis, your rhomboids, your serratus anterior, and your intercostals. Now, why does dysfunction happen? Sitting for hours with a forward head position is going to lock up your mid-back. Poor overhead mechanics in the gym can also overstrain your mid-back and potentially cause shoulder pain. We'll talk more about that in the future. And a lack of rotation in golf, pickleball, or throwing sports. Rib restrictions or shallow breathing patterns, and weak mid-back musculature. Now, the big myth to bust at the mid-back is thinking that you need to stretch your mid-back more. Not necessarily. Tightness often feels like weakness, and weakness often feels like tightness. Protective stiffness is what this is called, and it's due to instability or weakness at the mid-back. Stretching without adding strength is like loosening bolts without checking the frame. Clinically, a stiff or immobile thoracic spine throws off everything, especially your shoulders and or your elbows. Now, let's get to the shoulders. Now, a lot of times when people talk to me about shoulder pain, I like to refer to it like a second floor unlevelness in your house. If you think your second floor is unlevel at your house, is it could be unlevel, yes. But should we also check the foundations? Absolutely. And again, those foundations are at your thoracic spine. However, the second floor can be unlevel and your foundations can be rock solid. So that's where we want to look at the shoulder. Now, the shoulder is mobility with a price tag. Now, this shoulder joint is the most mobile joint in your body and is also one of the least stable joints in your body. And it's made up of 4 joints, not just one. Your first one is your glenohumeral joint. That's right here. This is often what people are referring to when they talk about their shoulder. The next one is their scapulothoracic joint. And that's the relationship of your shoulder blade to your ribs and thoracic spine. The next one is your acromioclavicular joint, also known as your AC joint. That's right here where this hard part is on your shoulder. And then the fourth one is your sternoclavicular joint. That's right here and where your collarbone or clavicle meets your sternum. Also, let's continue to consider the structure of the shoulder. Now, the only bony attachment your shoulder has to your body is your shoulder blade back here attaching through your acromioclavicular joint to your clavicle. So really, the only bony attachment your arm has to your body is your little clavicle. People break it all the time. It's not a very tough bone. That's it. So how does your shoulder truly attach to your body? It's really how your shoulder blade attaches to your rib cage and your thoracic spine. Again, we call that your scapulothoracic joint. And that's where your serratus, your rhomboids, and your trapezius muscle will attach your shoulder blade to your rib cage and thoracic spine. Now, the movements of your shoulder include flexion and extension behind your back, abduction, and then adduction, internal and external rotation, and scapular upward rotation and elevation, protraction, and retraction. So there's a lot of movements. Like we said, the shoulder is one of the most mobile parts of your body, meaning also it's the least stable. Now, the key muscles involve your rotator cuff for your shoulder, and the rotator cuff is actually a group of 4 other muscles that include your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. Then outside of the rotator cuff, you want to include your deltoid, your trapezius, your serratus anterior, your lats and pecs. And then there's other various little muscles that attach, but those are your major muscles. Common causes of shoulder dysfunction include poor scapular mechanics, a weak serratus or lower trap, overhead lifting without proper thoracic extension, impingement and/or poor mobility of one of your ribs, and muscle imbalances like your pecs and rotator cuff. Now, the major myth to bust at the shoulder is my shoulder hurts, so it must be my rotator cuff. Well, not always. Pain is often referred from a dysfunction upstream, especially at a stiff thoracic spine or stiff ribs. A proper shoulder recovery plan should always include scapular stability and thoracic mobility. So again, shoulder pain does not always involve just your shoulder, but can also lead to your thoracic spine. Now, what's also very common is untreated thoracic spine and shoulder problems often lead to your elbow becoming a problem. It's frequently a victim of poor shoulder mobility. And here's the deal with elbow pain. It's usually not just the elbow that's the problem. Elbow dysfunction is frequently a downstream consequence of your shoulder and wrist issues. So that's why you can treat the elbow and see 0 results because you're not treating the source. Common culprits of the elbow involve poor rotator cuff weakness or poor rotator cuff strength, leading to rotator cuff weakness, poor scapular stabilizers, severe bicep tendon irritation, poor external rotation, poor grip strength and wrist mechanics, severe wrist rotational weakness with poor pronation and supination, and several other problems. Common elbow pain patterns include lateral epicondylitis, like tennis elbow out to the side, medial epicondylitis or golfer's elbow, bicep or tricep tendinopathy, ulnar collateral ligament strain for throwers, and nerve entrapment like the radial nerve and the ulnar nerve. The major myth to bust here at the elbow is if it hurts at the elbow, treat the elbow. That's frequently not the whole picture. That's like putting a bucket under a leaky roof. You're managing the symptoms, but you're not fixing the cause. If you're not addressing the shoulder control and the thoracic posture, the elbow will keep taking the hit. Now, major red flags to consider are neurological signs like severe numbness and tingling or weakness of the arm and visual atrophy of hand muscles and loss of coordination at the hand, where you just kind of miss objects. Another one that might consider like a fracture, severe instability, is looking at the mechanism of injury. Like, did we have a car accident? Do we have severe swelling, visual disformity, crepitus because the bone is very unstable, or instability and inability to lift the arm at all? Vascular concerns might be cold hands, severe discoloration like severe purpleness, blueness, or whiteness at the hands, or pulselessness, meaning I don't even feel a pulse at your hand. Systemic concerns to consider is persistent night pain, a history of cancer, and unexplained weight loss. If any of these show up, we should skip the massage gun and call your doctor. Now, the clinical model that we use here at OrMobility involves looking at your posture, range of motion, strength, control, and function. So let's bring it home and talk more about our framework. Now, posture, a neutral, adaptable base, and especially thoracic posture is critical. A lot of times thinking of this hard part, that AC joint that we referred to, and thinking like, is that in line with my earlobe? And when I turn my head, is my earlobe still in line with my AC joint? The next thing we want to consider is full range of motion. Not just trying to be Gumby and get more range of motion, but full range of motion. Talking about 180 degrees of flexion, 180 degrees abduction, 90 degrees of external rotation, and 70 degrees of internal rotation. All of those are very important, but getting more of that isn't necessarily important. We want to try to think then next about getting strength there. We have the range of motion, but we want to be able to do something with that range of motion. Then the next aspect after posture, range of motion, strength is control. We can be very strong, but we have to be able to control the car. And then finally, bringing that together is function. Can I lift overhead? Can I throw? Can I reach? Can I push? And can I do this powerfully and pain-free? That's what we mean by function. We like to use this model whether we're treating elbow pain in a tennis player or shoulder impingement for an office worker. We want to fix the chain, not just the link. So that's what we wanted to talk about today at OrMobility and our OrMobility podcast. So if you've been stuck with using the foam roller on your traps or chronically icing your elbow or wearing straps and braces, I hope you take away some of this information because this could be why you have to chronically keep using those modalities. Now, if you'd like to, please share this episode with someone else that you may know. We're right here in Roseburg. And if you'd like to get connected with us, please feel free to check out our website, ormobility.com. That's ormobility.com. And you can fill out a form or you can call us directly at 541-845-3311. Again, I'm Dr. Garrett Stroup, Doctor of Physical Therapy, and we'll see you next time.